So the first thing I'd like to talk about is the anatomy of the spine. And as you may know, it's commonly divided into three parts: the cervical, thoracic, and lumbar sacral spine. And as you can see in this picture, the top 7 vertebrae are called the cervical spine. Those are the ones in the neck. The next 12 are the thoracic spine, and that's your rib cage. And the lumbar sacral spine are is below the thoracic spine, and that's the low back. So to go over the general anatomy of the bones, this is the image of a cervical spinal vertebra, and they pretty much all have the same outline. There's this part of the bone in the front of the spine called the vertebral body, which is a thick, strong part of the bone which provides most of the structural support. There is a canal in the bone, which is the hole in this bone right over here, which is where the spinal cord is and the spinal nerves are. And then there are bones coming out, pieces of bone rather, coming out the sides of the spine and in the back, including the spinous process. And this is what you feel when you push down hard on the back of your neck. This is an image through the middle of the spinal canal in the neck, in the cervical spine. And you can see the spinal cord. And the other main structure I want to point out here is the disc, which is between the bones. And that provides support as well as cushioning for the spine. And it typically always consists of 2 main parts. There's you can think of it as a jelly donut. So there's the annulus fibrosus, which is the tough outer donut part, and there's the inner stuff called the nucleus pulposus, which is the jelly. And commonly what happens when we talk about disc herniations is some of the soft material, the nucleus pulposus, is squeezing out through the donut, through the tough outer membrane. And you can see that in these 3 levels, that's what's starting to happen. This is an image of a bone in the thoracic spine. It's very similar to the one in the neck and the cervical spine. You can still see that there's this thick part of the bone called the vertebral body. You have the spinal canal. But the one big difference here is there's a little joint here for the ribs. And every thoracic vertebra is joined to a rib. There are 12 ribs, 12 vertebrae. And together it forms the thoracic cage, which is very strong and provides a lot of support, but it's also very stiff. So one of the big differences rather between the thoracic spine and the cervical and lumbar spine is there's very little motion in the thoracic spine. So for example, if you lean forward 90 degrees, you'll find that the motion comes primarily from your hips and your low back, with very little motion, if any at all, from the thoracic spine. It'll remain completely straight. The neck has the most motion. There are about 5 to 10 degrees of motion in each direction per level, and 30 to 40 degrees at the top 2 levels. And the lumbar spine is in between. So this is the image of the lumbar spine. And on the right side, you see the MRI image of the lumbar spine, which is one of the best ways to evaluate problems in it. And you can see the same structures. There's the vertebral body right here, and the discs are right over here. And what you can see is that these discs are nice and tall and white, meaning they're very well hydrated. As they degenerate, they typically get darker and shorter, and sometimes they start pushing out. I will go through that in just a bit. Now, the last part of the spine that I wanted to discuss, the sacroiliac joint. And that's a much less talked about part of the spine. It's often very under-treated and underdiagnosed. And some studies actually show that up to 20 to 25% of back pain is actually due to the to the sacroiliac joints. And the sacroiliac joint is the joint between the sacrum, which is the middle part of the lower part of low back, and the ilium, which is the big pelvic bone on each side. And if you feel in your low back and go about 1.5 inches off of the middle, you'll feel a bump. That's the sacroiliac joint. And that commonly causes back pain. It's unfortunately underdiagnosed, and the treatment for it is different from treatment for other parts of for other reasons for back pain. And that's why sometimes treatments don't work very well. The last part of the anatomy I'd like to go through is the muscles. Now, I'm not going to go through each individual muscle in the back, but the main goal of these pictures is to show that there are a lot of muscles in the back. Yes, question? I'll actually touch on that in a little bit. It's a great question. We'll go through it towards the end of the talk. So as far as the muscles go, there are a lot of muscles. They connect the back to your arms, your shoulder blades, your legs, and that's why when there's an injury in one of these muscles, and the muscles say connects the spine to your arm, then moving the arm can reproduce the pain in the back. So that's commonly called a muscle strain. So these are the top reasons for having back pain and pain shooting out to the arms and legs. The most common reason for back pain is a muscle strain. Then there are disc herniations, fractures or broken bones, tumors, and sacroiliac joint. So what is a muscle strain? Basically, a muscle consists of a bundle of fibers, which are held together in a membrane. And when some of those fibers are torn, we call it a muscle strain. Depending on how many of those fibers are torn, we can grade it grade 1, 2, or 3. And typically, the body tries to heal the muscle strain by bringing in a lot of blood cells and nutrients and whatnot, and it causes a big inflammatory response. This inflammation often causes pain in itself. And typically, these muscle strains, especially the low-grade ones, will just heal on their own. And that's when you have back pain, which goes away within a couple of days or a week or two. And most of the time, that is the case. When it doesn't, then it likely means that the strain is of a higher grade, and every time you move, you aggravate it, and it just doesn't get a chance to heal. In those situations, these strains do need help healing, and that's where modalities such as physical therapy or steroid injections or anti-inflammatory medications may come in. The one thing about muscle strains, though, is that surgery has no role in treating it. It's never an option. It just doesn't work. The next problem I'd like to speak about is a disc herniation, and that's what we discussed a few minutes ago when the soft jelly inside the disc is being squeezed out. Well, you can see in this picture from the looking at this cervical vertebra from the top down that this jelly is squeezing out, and it's pinching on this nerve coming out of the arm. And this can cause a lot of pain, just like if you step on the water hose, water can't flow. Same thing here, there's pressure in the nerve, signals cannot get through, and you can start having pain, numbness, tingling, warmth type sensation, electrical shock sensations. And we've done actually a pretty good job of mapping out where each individual nerve goes from each level in the spine. And this is a map called the dermatome map of these nerves. And what you can see is that this nerve, which comes out between the 7th cervical vertebra and the 1st thoracic vertebra, would be the C8 nerve. And looking at this chart, you can see that the C8 nerve goes to the goes down the inside of the arm to the small finger and the ring finger. So if you have pain shooting down to these two fingers and the MRI shows this disc herniation, then it makes perfect sense as to why this disc herniation will be causing the pain. If, on the other hand, you have pain shooting out to the shoulder or to the thumb, and the MRI shows this disc herniation lower down, then it means that there's something else going on, and we need to look a little bit deeper to find the real source of the pain. Typically, when there's concern about disc herniation, we evaluate it with radiologic studies as well. We just about always start with x-rays. They give us a good idea of the overall alignment of the spine. It shows us the bones very well. It also shows the spaces between the bones where the discs are, and that's right over here. And while the x-ray doesn't show the disc itself, it can show that the space is narrowed, meaning that the disc material had to have gone somewhere. And that's and in those cases when we want to know where exactly this disc is or disc herniation is, we get an MRI, which is the study you see on the right. And this goes through the sagittal or the down the side view of the cervical spine, and you can see that there's a spinal cord right over here. This disc is fine, this one is fine, but these two are herniated, and they're pushing into the nerves and the spinal cord, and that can very well cause a problem if some of the signal transmission is inhibited. So how do we treat disc herniations? And most of the time, we treat it with non-surgical modalities, and it's very successful. Unless there are neurologic symptoms, neurologic deficits rather, such as numbness or weakness, we just about always start off with pain medication and physical therapy, and sometimes epidural steroid injections. And these modalities are usually very successful in treating probably 80 or 90% of disc herniations. When that doesn't work, or rather, if it's not successful, we have a choice. If there are no neurologic symptoms, then there is a choice of either living with this or trying one of the alternative methods, such as chiropractic treatments or acupuncture, a variety of others. Or we can talk about, we can really pinpoint the problem to where nerve is pinched by a disc and it correlates well with the symptoms. Then we can talk about surgery. Now, when talking about surgery for the cervical spine, there are two ways to approach it. One is from the back, and the other one is from the front. Surgery from the back is done through a minimally invasive maneuver where we make a small incision and under a microscope can put a tube in and go right down to the bone, cut out a piece of the bone, and hopefully relieve some of the pressure in the nerves that way. This, while in theory this looks like it would work well, it doesn't always work very well, and it's not the right option for most cases of disc herniations. However, for specific selected cases, it's a great option because you can go in and go home in the same day, and the recovery is very straightforward. The other type of surgery is called the anterior discectomy and fusion, and that's where we make a small incision in the front. Again, this is minimally invasive, done through with the use of a microscope, but it's more of a surgery than the one from the back. And we would go in, take out, go between the structures in the neck, take out the whole disc, make sure there's no pressure left on any of the nerves, and then restore the appropriate height of the space between the discs, and put a carbon fiber cage in between to keep it there, and a thin titanium plate in the front to hold it all in place. With this treatment, the success rates are actually very high. They're about 90%, meaning that still there's always a chance that it may not work, but most of the time it does work very well. There is some concern about loss of motion because there is a fusion, and about 5 to 10 degrees of motion can be lost per level. And it's a decision that has to be made, and the risks and benefits have to be carefully weighed before proceeding with the surgery, but when done for the right reasons, it works very well. This is a post-operative film of somebody who had those two disc herniations, and you can see the titanium plate with the screws on these x-rays, and you can see how now there's no pressure at all on the spinal cord or any of the nerves. Now, the same thing can happen in the thoracic or lumbar spine. It's uncommon to happen in the thoracic spine just because there are the ribs protecting it, and when the pain does come, it will typically shoot out to where the nerve goes, which is around the rib. And this is usually treated very successfully with injections and physical therapy. Surgery for this is much more invasive, not nearly as successful, and typically best avoided. Now this is an image of the lumbar spine of the low back, and this is the most common place to get a disc herniation. And again, you can see the MRI on the left and the schematic on the right. You can see how this dark stuff, which is the disc, is pushing out and squeezing into and pinching the nerves, and this would cause the pain shooting down to wherever those nerves go, which for this location would typically be the side and the back of the legs. And in this case, we can again try the non-surgical treatment modalities. If they're successful, then great. If not, then a surgery can be done. And in this case, it's actually, again, it's typically a minimally invasive surgery called microdiscectomy, which is done through an incision about 1 inch long. And it's pretty much very straightforward. You go in under a microscope, go right down to the disc herniation, pull it out, and that would be it. There's no fusion involved. The surgery takes about 45 minutes to an hour, and you can expect to go home the same day or the next morning. And success rates are in the 90 to 95% range. Again, nothing is 100%, but typically it's very successful, and it provides long-term pain relief. Now, one of the reasons we get x-rays is because often there's an underlying structural problem with the bones, such as instability or poor alignment, such as scoliosis. this is an example of such a problem called spondylolisthesis, where instead of just the disc slipping, the whole vertebra, the whole bone is slipping forward. And you can see how these bones line up very well up here, right up here, and down here it's shifted forward by probably half an inch or so. And when it does that, you can see that the nerves, which on the right are being squeezed. The light stuff is the nerves, and it comes out again, and you can see this almost an hourglass-like image where the nerves are being really squeezed, and then it opens up again. And that is a common cause for pain in the back and pain shooting down the legs. And this typically happens in starting with the 5th or 6th decade. So the treatment for this is more extensive. It usually cannot be treated with minimally invasive methods, and we typically do a traditional open surgery with open decompression and then fusion with the screw rod construct. Now this is a bigger surgery. It takes about 3 to 4 hours, and the recovery is longer, although by 2 to 3 months the recovery is pretty much done. And it's very successful. Actually, National Institute of Health did a big study called the SPORT study, or Spinal Patient Outcome Research Trial. And we have data now extending to 8 years after surgery. And what they found after looking at several hundred patients across 11 spine centers in the country is that success rates are very high. They're about 90%. And typically the results stay. So once the problem is fixed, it stays fixed. So the results at, say, at 8 years after surgery are almost or just as good as 1 year after surgery. But again, it's a real surgery. It should be done only once the non-surgical treatment options are tried and are found to be non-successful, and the symptoms are severe enough to interfere with your life. But when done for the appropriate reasons, it works very well. And again, I want to touch on the sacroiliac joint. The reason that I bring it up again is that it's a commonly misdiagnosed cause for back pain. And often when back pain doesn't get better with physical therapy for about 6 weeks or so, and there is no underlying cause that can be found in X-rays or MRIs, you really need to look for the sacroiliac joint to be the cause of pain. There are some tests that can be done, and if it's confirmed to be the cause of pain, then a steroid injection is usually very successful for it, but it has to be done in exactly the right spot. Any questions so far? In the back?
What kind of shot was it called?
It's a steroid shot, and the common name that everybody refers to it by is an epidural. But an epidural injection is a conglomerate of a variety of different injections, including facet joint injections, transforaminal injections, caudal injections, interlaminar injections, sacroiliac injections. They're all done to treat different different pathologies. They're typically done under X-ray, and depending on the specific pathology, they can range from being very successful to being not successful at all, and sometimes they do need to be repeated. But it is a steroid injection that's done under X-ray.
Thank you.
No problem. So next, I wanted to talk about fractures, and this is an example of a compression fracture. There are 3 main fractures I'm going to talk about. This is the one that's the most common, and it can be very painful at times. Now, you've probably all heard about a compression fracture. What is it? It's basically compression of the anterior part of the bone or the vertebral body. And you can see how this bone is nice and square on this MRI image, while right here, you can see that it's almost like squashed, like a can of Coke. And it's usually squashed from the front, so it assumes a trapezoid shape. And you can see the same thing on an X-ray right here. Typically, these can cause a lot of pain. They almost always heal on their own just with time. And sometimes a situation comes up where you may have a new incident of back pain. We get an X-ray, we see this compression fracture, but it may very well be an old healed fracture. In this case, we can get an MRI, and if we see this white fluid in it, then we'll know it's a new compression fracture as opposed to an old one. And the reason this is important is because the treatment is different. For a compression fracture that's new, treatment consists of activity modifications, pain control, bracing at times, While if it's a no compression fracture, then we treat it as a muscle strain with physical therapy, which is not something you want to do in the compression fracture. And in response to the question earlier, when you have a couple of these fractures in the thoracic spine, then the spine may actually curve forward a little bit to assume the more forward flexion type appearance. These fractures are usually caused by one of two things. The first is osteoporosis, or weak bones, and that usually happens later on in 60s, 70s, and 80s. The second reason is high energy trauma or a fall from a height such as a third-story window. In those cases, you can also get a compression fracture. But an important thing about the compression fracture is it's often the first sign of osteoporosis. So just because the fracture is there and you get it treated and it heals, doesn't mean that you're done. It's a sign that you need to be evaluated for osteoporosis and to see if there's anything else that can be done to strengthen the bones to avoid a much more significant fracture such as a hip fracture in the future. Now the treatment, as I said, is usually time, bracing at times, medications. And when that's not successful, we can try surgery. This surgery, in my opinion, has been overdone somewhat over the past 10 years, and it's being done less now because we found that most of the time it does get better without it. If it does need to be done, though, it can be done minimally invasively through 2 incisions of about an eighth of an inch each. And what it involves is putting in a needle and introducing a balloon inside the bone itself, and inflating the balloon, as you see here, to restore the bone to its original shape, and then injecting special bone cement, which will provide support. And the pain relief is usually instantaneous. Now, the surgery itself is outpatient and takes about half an hour, but it does require general anesthesia typically, and for those reasons, we really try to limit it to only situations where it's really needed. Now, it's important to differentiate this type of a fracture from a more serious fracture called a burst fracture. And that's where, instead of just the front of the bone being broken, the whole bone is crushed, and you can see that there's a piece back here that's pushing out of the spinal canal. This is a much more serious injury. This typically requires some type of a mechanism, such as a car accident or a fall, to happen. And this can actually cause neurologic symptoms, such as numbness or tingling or pain shooting down the legs. The treatment is completely different. We're usually much more aggressive with it, especially if neurologic symptoms are present. And in those cases, we have to go in and fix the fracture. At other times, if no neurologic symptoms are present and there's no significant deformity, then bracing it for 3 months is typically successful. And on the right is a much more serious type of an injury called a fracture dislocation. And that's where the whole spinal column is shifted forward over the bone below. And usually nerves are involved in this. There can be nerve damage or even paralysis, and this requires urgent surgery. But thankfully, it's much less common than the other problems. Now, the much less common reason for back pain is tumors and infections. And tumors are typically metastases from other areas of the spine. But if there's a history of cancer and there's a new onset of back pain, then it's very important to look for a possible tumor or metastasis because that may be the cause of pain. The treatment for this really depends on the underlying cancer problem. If it's a metastasis and it's a late-stage cancer, we may not be able to get the whole tumor out, and the treatment may be limited to just treating the pain. Whereas if it's small and there are no other sites of tumors, then we can typically take it out and restore the height with the intervertebral device and bone graft. And often this is successful, but it's really individualized treatment based on the underlying reason for the tumor. Infections are also possible, and typically you see this lighting up of the bones with osteomyelitis or bone infection. It's much less common now than it used to be, in large part because we're much more aggressive with infections and we have great antibiotics that can treat them. And also because tuberculosis is under much better control. Tuberculosis used to be a major reason for spine infections. It's even 40 years ago, 50 years ago. You may have heard of Pott's disease, which is infection of the tuberculosis in the spine. It's much less common now because we've become much more aggressive with it. Still, if an infection is present, it has to be treated. Typically, it doesn't involve surgery, and it involves antibiotic treatment for anywhere from 6 to 12 weeks. But at times, surgery is necessary if it's just not getting better or if the abscess is present. And I'd like to devote the rest of the time to any questions you may have.